Good morning, ladies and gentlemen. So basically, this was the talk should be given by Jay, who has done a phenomenal work on the choroidal imaging, but unfortunately he could not make it. So we were talking about the choroidal imaging. We all know that choroid has, and these are my disclosures. Choroidal, why to do image the choroids? We have known since long that choroid is an important layer, and over the time, with the help of multimodal imaging and other imaging, we know that ICG was the only thing which we were using before, but it was giving the perfusion analysis. But over the time, as we grown the technology, then this was the first paper which has changed the way we looked at the choroid. The paper was published by the Spade when he gave the first technique that how you can image choroid with even the SDOCT by giving the EDI, by just putting the zero delay line further back. And in a normal SDOCT machine, everybody could do it because that is the machine which is there predominantly at each and every center. But what was happening was, that vitreous details were compromised. So over the time, the need was felt, okay, is there any way that we can actually see both vitreous and the posterior most part like choroidal scleral boundaries little better? Then with the help of swept source and the better wavelength, we could see that. And we could see the little larger area also. So the normal choroidal thickness, if you talk about, is 191.5 up to 354. You can see that's a wide range. Why is that wide range? Because the choroid varies with a lot of factors. There are a lot of factors. For example, it varies with the advancing age. It varies with the myopia. It varies even within a day. So that is the reason that you see a quite variability. Even in the range is quite variable. So over the time, initially it was only manual when we were taking the outer boundary, the RP and the choroidal scleral junction and putting the line manually. But over the time, when the auto-meta segmentation came, it became a little easier, and over the time techniques have developed that you can actually measure the choroid, for example, with binarization a little better. Then to even just one cut is not enough, so you need to look at the up and down and over the volume what is happening. I think that could give a better information. So that was considered, and furthermore choroidal vascular index was considered, and it was supposed to be a little more stable compared to the choroidal thickness alone. So as on-fast imaging, Dr. Unni has already highlighted beautifully choroidal contour, 3D reconstruction, we are trying to look at it, OCT highlighted beautifully by both the previous speakers. So let us see what actually we have learned out of this choroidal imaging and what is the kind of importance that you have. So this was the first entity which was again described by the Spade, that what you see is there's a severe choroidal thinning that you see here, but RP looks quite intact. So the entity was age-related choroidal atrophy. So the way you can differentiate, you should not get confused between the GA and the age-related choroidal atrophy, because GA could have a worse prognosis. Rather this entity, because the RP is quite intact, so the prognosis is quite good. So you can predict things once you see these images. Further, myopia, with each degree of the myopia, as you can see that choroid gets thinner, but it doesn't, it's not necessary that you can have a correlation with the visual acuity. And again, this is the entity, dome-shaped maculopathy. Again, the concept was cleared after we had this imaging. Previously, the concept was that because of the staphyloma, both the sides of the sclera were sagging in. But actually, that was not right, because the center where the dome is, the sclera was pretty thick. And because of the sclera, there was a compression in the choriocapillaries, which was producing a pseudo fluid. So that fluid you actually need not to treat because not a CNVM. Furthermore, CSC management, right from the concept, right from the understanding up to the management, choroidal imaging has really, really helped us, and we have learned a lot. For example, if you see this particular patient, you can see after focal laser, you can see a quite thick choroid, and after focal laser, choroid thickness doesn't change. While after PDT, you can see the choroidal thickness goes down further. So we could understand, both the things both the treatment, they work in a different way, and PDT could be a better option in treating this in a long term. Another disease, which again we learned after choroidal imaging a lot. For example, it has again changed the way we treat them. For example, this is the right eye and the left eye of this patient. At the initial visit, you can see a quite boggy, thick choroid. Actually, you can't even see the posterior boundary itself. But once you start treating them, after 3 doses of the pulse therapy, then in this particular right eye, everything is crescent, even choroidal thickness goes down. Here, choroidal thickness goes down. But after the 3 weeks of the steroid pulse therapy, the recurrence comes here again, but there is no retinal changes here. But as you can see down further, the choroidal thickness comes back. So probably, you know, these are the situations where choroidal thickness really helps you. Okay, now the recurrence is going to come in this particular eye, so you can treat them. And again, pachychoroid, again, the choroid has a really, really important role. Our understanding and even the definitions still keeps changing, but understanding is that, you know, outer layer, they are quite big, and they are compressing the inner smaller vessel layer. So it's a kind of a spectrum which starts. Previously, we were thinking in all these, you know, subtle RP changes that, you know, these are probably the healing CSR cases, but probably not. Probably those cases were the initial pachychoroid pigment epitheliopathy, further leading to CSCR, leading to pachychoroid neovasculopathy. As Dr. Anand said, you know, now the definitions are changing. Now we don't call anymore type 1, type 2. It's all, you know, whatever vascularization that you have at the macula is basically a MNV, macular neovascularization. And you know, apart from these central macular, you have some understanding of intraocular tumors also. But in terms of the tumors, actually, fundus photograph gives you quite a lot of information. But still, there are situations where you can differentiate. For example, in a melanoma cases, you can see a gentle dome shade, quite a smooth surfaced area down. But here you can see, in cases of hemangioma, a lot of hyporeflective vessels that you can see underneath. So you can differentiate. In metastasis also, there's a lumpy, bumpy RP, but you can see the, you know, choroid, and further back you can see the sclera, which you don't see in cases, for example, sclerochoroidal calcification, because the sclera is coming from the down, and it is basically compressing the choriocapillaries. In lymphoma also, you have the lumpy, bumpy, but basically there's a quite huge undulation, which we call as a C-sick appearance. Osteoma is actually, you can't miss it even with the help of fundus photograph, but still, if you want to image, you can see the intralesional horizontal lines. So now you can ask that why are you not, you know, talking about the AMD, DR, retinal dystrophies in cases of the choroidal imaging? We are still not clear, because the AMD has a multiple component. Now we are growing towards, you know, trying to define and separate the AMD as MNV, and even the choroidal thickness. In a few slides I will say that how the AMD would change in future. So this is again, you know, when you actually measure the scleral thickness with the help of your caliper, sometimes it's not very easy to find the boundary which you have at the at the back, because there are multiple times there is a fuzzy kind of, you know, bend that is there, and that is called the suprachoroidal space. Probably in few eyes you have that suprachoroidal space, but if that is, you know, that is the case in many cases, then probably, you know, the entire thickness, because it's all about the millimeters, entire thickness might go, you know, in a haywire. So that concept we need to still clarify. So for that, you know, there is a good paper where you can actually check the scleral thickness in 3 ways, which whatever inner area that you see, that could be the vascular choroidal thickness, in between the stromal choroidal thickness, and the last line, this could be the total choroidal thickness. So if we can divide all these 3, probably we can have the better understanding. AMD definition is changing. If you look at the recent paper by the Spear again, so the way in future, again, things might change. You might, you know, these are all the drusen's. We see drusen's day in and day out, but you need to really look at the drusen. What kind of drusen are we dealing with? For example, this is the eye of in the left eye, which is, we call as a pachydrusen. And the pachydrusen, if you see, on the affected eye, you have the PCV. On the other eye, you have quite a thick choroid. So, and in the middle, there are soft drusens. In the other eye, there is a type 2 CNVM, while this eye, there's just the drusens, soft drusens. In this particular, these are the pseudodrusens, and then this particular patient, there's a rap lesion. So what is going to happen in near future? You see the choroidal thickness. You have these drusens, and somebody would ask, you know, this is the drusen that you have, and this is the choroidal thickness of that particular patient. So what, you know, so then retrospectively you can answer, okay, this could be the pachydrusen, this could be the pseudodrusen. So in that way, I think we are going in a different way to define the AMD going forward. To summarize, choroidal thickness is highly variable individual, decreases with age and axial length. Choroidal volume shows almost similar interpretation as choroidal thickness. CVI, choroidal vascular index, has little low variability compared to the CT, choroidal thickness, and fast imaging has improved the vessel detection, especially in cases of the PCV. OCTA gives you real good information as the early CNVMs and the type 1 CNVMs, and AMD might be redefined by the choroidal thickness over the time. Thank you.